I have a difficult challenge. I have to convince all the audience, the few who are remaining, no, I'm joking, you are all remaining, on the role of not really radiotherapy, but what we call radiosurgery or stereotactic radiotherapy, and we'll see the differences in a minute for the treatment of metastatic disease in general, but more precisely, of course, for kidney tumors. So we all know the rationale, and we had very nice topic from Dr. Calabro, Dr. Badvev on is there a role for local treatment in the metastatic setting, surgery, or something else? And if we do so, when do we do so, and how do we do so? So I'm trying once again to convince you that indeed there is something to do with radiation in general, and of course with radiosurgery and stereotactic radiotherapy. I'm entering a field which has been very clearly defined by the US North American colleagues, which is the field of ablative treatment using radiations. That's something you all know in brain. You all know that radiosurgery is a standard treatment for brain metastases, and there is no debate on that. So I could stop right now and say it's a standard. At least it's the standard in brain. And I think you will all agree on that. But of course, the most interesting topic is outside brain. Brain is relatively easy, it doesn't move too much. Outside of brain, it may move, and when it moves, it's an issue for radiotherapy in general and stereotactic radiotherapy in particular. To be clear with you, I have to give you some definitions. I'm sorry about that, but discussing to colleagues outside of the field, sometimes definitions are very important. What we call a stereotactic radiotherapy is the way to deliver very high doses of radiotherapy in very well-defined targets with a precision of a millimeter. So it's a real challenge. But you should know that it is that possible today, even outside of the brain, because the machines which are able to deliver very high doses with a millimeter precision in moving targets do exist, and they do exist around your own settings. So it's possible to fit with that very strict definition and deliver the very precise radiosurgery or stereotactic radiotherapy. Mostly in Europe, we say radiosurgery when we consider a single fraction, and it's typical of brain. Radiosurgery means once only. When we go to stereotactic radiotherapy, in general, we go to 1 to 5 fractions, no more, because otherwise it's fractionated radiotherapy, and it's a different word, maybe the word you had yesterday. So we are in this very precise word, a few fractions, very high doses, very precisely defined. Let's see some results outside of the kidney right now, and then we'll enter the renal cell carcinoma. This is data we have published in my own department with something which is considered to be relatively radioresistant, which is colorectal tumors. And if you look at the results for this colorectal liver metastasis, we very nicely demonstrated in my department that the probability of local control was very high, above 90% at 2 years, if we were able to deliver high dose. When I say high dose, I say 3 times 15 gray. It looks like 45, but by the way, in the biology of radiation, it's not mathematics. This 45 is a physics dose. The biological dose is twice that dose. So be very careful. When we talk on stereotactic radiotherapy or radiosurgery, delivering 45 gray in 3 fractions mean delivering 90 to 100 gray at comparison with classical fractionation. So I can tell you, at that kind of dose, there is no radioresistant. Not a single tumor is resistant. But we have to be very careful, and we have to very precise define the volume. And I will show you how. So if you look at local recurrence-free survival in this group of more than 150 patients, we have very recently published, we demonstrated clearly that the volume was important. Of course, if you deal with big tumors above 5 centimeters in max diameter, it starts to be difficult, but even so, you do control half of these patients. But if you deal with small tumors or relatively small tumors, and if you deliver high dose, even in considered to be radioresistant tumors, you are very efficient. And even in very radioresistant tumors, you can be very efficient. This is, of course, palliative treatment, but it's a very big liver metastasis from a primary skin melanoma. And you can see that 51 months later, this patient was quite fine. And he was an 81-year-old patient, something very important too, because, of course, this treatment is non-invasive. It could see it just like a miracle. It's not. But of course, there are difficulties. And the most important difficulty is to rightly select the patient. So I think we had a very nice talk this morning on how to select the low burden, the high burden, the patients with relatively, I would say, latent tumors, or the ones with very aggressive tumors. This is totally fitting in my talk, so I'm not going to spend time on that, but what we have here today from, for example, Dr. Calabro is exactly what is fitting with the use of SBRT, stereotactic body radiotherapy. Let's see some clinical examples. This is coming from my department, a 63-year-old man with a relatively big tumor, metastatic from a renal cell carcinoma. We were 4 months after the initial surgery of the initial primary kidney tumors, and you can see that this patient had quite a big tumors. It was very painful. That's why he was referred to us, because people, the colleagues, the medical oncologist colleague and the urologist were thinking that this was difficult to do surgery on, and this was very painful, so there was no point waiting for some efficacy from targeted therapy. And that's how we did deliver the dose, and once again you can see that it's very precise delivery. 90 gray, dose equivalent, no critical organs. The lung is very well respected. The only critical organs in such setting could be the ribs. And you have to be very careful, but because, of course, toxicity on the rib is something, but as you can see, the rib was already nicely broken. So that's an issue. 7 centimeters in max diameter. This is a result 26 months later. Okay, this is very classical. If you go back home and if you talk to people around you in radiation oncology departments, we are used to deliver stereotactic radiotherapy with that kind of dose, 3 times 15, with the right equipment and the right definition of the target. This is very classical. Once again, it's classical in brain, it's classical in lung. It's a reference treatment for lung metastases from colorectal cancer. It's same nowadays in liver. So nothing different. I have just to convince an audience which is not really, I would say, keen with that it's for other topics very, very classical treatment. Just one word on primary, because it's a different issue and I'm not sure that there are many data. I will show you some data to conclude on primary tumor. We have treated in my department a few primary kidney tumors in very specific clinical situations dealing with our urologist colleagues from Professor Arnaud Viller's department. And this is a classical example. I'm not sure there is too much role, except maybe, but I would not like to reopen this morning debates on partial nephrectomy, on the role of potential radiosurgery before some kind of surgery. You know, it's standard treatment in oncology in some clinical settings like advanced rectal cancer. Of course, it's a different story. But if you do so and if you look at the literature, there are a few data presented, that's true. But this is typical of a very nice tumor necrosis you can observe after a relatively low dose of stereotactic radiotherapy. What you see here is the fiducial, that the gold grain we do implant for tracking the tumor, because kidney is moving and you have to track the displacement of the tumor if you want to be very precise. But you can see that is something which is very efficient on a pathological point of view. For you to know, in hepatocarcinoma, we are now starting worldwide, one in US and one in Europe, studies. So hepatocarcinoma is a different topic, but just for you to know, delivering radiosurgery 3 times 15, stereotactic radiotherapy, before liver transplant, just to wait for the liver transplant. And there is no issue for the surgeons by delivering such a treatment before doing liver transplant for primary hepatocarcinoma. I know it's a different story, but I think there are some issues to talk about. My last slides, I had only 10 minutes. I hope I'll be on time. I will. Some results from lung metastases, from kidney, just kidney, or for primary. My point here will be very classical. If you look at regression and what is the impact of local control, it's once again very depending on the dose, very depending on the dose and the volume. You have to go to that kind of dose, once again, 90 to 100 gray, to achieve local control, but you do achieve. So the point is not waiting for too long, otherwise you decrease, of course, local control according to the volume. It's a classical volume effect, but you may deliver very high dose together with a very good tolerance. This was published very recently last year, and that's something you could find coming from the colleagues in Sweden. And that was primary and metastasis recurrence-free survival. The last point is, of course, we are not going to cure everybody by local treatment. And there is a big way to think about combining targeted therapy and local treatments. My conclusion will be exactly the same as from Dr. Matveev. We have a room for combining in a good way, in a bright way, in an elegant way, targeted therapy, which are, of course, very important, and local treatments. Is it possible with stereotactic radiotherapy? We have some results. This was published 2 years ago from Germany in 106 patients with metastases, spinal and cerebral, combination with combined stereotactic radiosurgery. It seems to be achievable with quite a good survival rate, but I would be relatively cautious to do it outside of clinical studies. And you had the question this morning on how do we combine surgery and targeted therapy or anti-TKI or antibodies, and that's something which is not totally solved. But of course it's possible, but if you do so, do it in prospective studies, and at least in Europe, 2 prospective studies are starting on that. So at the end of my talk, I'm not sure I did convince you, I hope so. But you should know that most of the colleagues in different fields of radiosurgery and stereotactic radiotherapy are dead convinced on the impact. Just remind that the doses are not the same and everything is really dealing with the dose. So could we be curative? Could we locally control for a long term? For sure. But please, if you do so, don't wait for too long because, of course, there is a real volume issue. And please go to prospective studies for evaluating the role of combined targeted therapy and stereotactic radiotherapy. Thanks a lot.